Hi, everyone. My name is Meghan Mardashti, and I'm one of the AOCPMR's Multimedia Committee co-chairs and your host for today's episode. In today's episode, we'll dive deep into the world of sports medicine and PM&R with our special guest, Dr. Dan Cushman. He is a board-certified expert in sports medicine and PM&R and specializes in musculoskeletal injuries and nerve disorders in athletes from weekend warriors to Olympians. He's the team physician for the University of Utah's track and field, cross country, swimming, and diving teams. Dr. Cushman completed his residency at the Rehab Institute of Chicago and fellowship at the University of Utah, where he now directs non-operative sports medicine research. With a focus on using exercise as medicine, he is a leading figure in sports epidemiology and MSK ultrasound. Join us as we explore Dr. Cushman's innovative approaches to sports medicine. And welcome, Dr. Cushman. We're so glad to have you. And if you could share a bit with our listeners as to what inspired you to specialize in sports medicine and PM&R.
Yeah, and thanks for having me. Um, I kind of have a non-traditional background where I was actually an engineer for 5 years, sitting in front of a computer over and over and over again. And it just really got to me after a while. And so I kind of naively went into medicine where I was like, oh, med school, that sounds kind of fun. Let's do that. Um, and I ended up going to the University of Miami where I did med school and then doing residency after that. But to get there, the whole reason I wanted to go into PM&R was actually sports medicine. And within sports medicine, you can get there from a few different avenues. But what I found was actually when I was in PM&R, I liked a lot of the other aspects of it, spinal cord injury. I really liked internal medicine, and there's a lot of internal medicine in PM&R as well. So for a while, I was actually really leaning towards doing kind of general PM&R because I enjoyed it so much. But then ended up doing sports medicine when I had all these pros and cons and everything like that. And I think originally the reason that I was thinking sports medicine was again kind of naive, where I was like, oh, I run, I bike, I get injured. I just want to be able to fix myself. But it doesn't really work that way. But I found that interest in medicine for people who are active is what has really kind of led me towards it, and I still like that aspect of it today.
Mm-hmm. Awesome. I love that. Medicine for people who are active. And I, especially like, there's definitely that misnomer of like, certain exercises or certain, I guess, models of workouts like CrossFit or more intense exercise regimens can really injure people. But there's the other side of like, obviously, it can help to prevent a lot of the other comorbidities. I just feel like that is a narrative that I've heard at times. Um, but also it's really cool to have such a passion and definitely coming from a non-traditional background. I wonder how would you say your engineering background helped you as a physician today?
Actually, as crazy as it sounds, it's computers. It's actually
Nice.
computers. Like we still use computers all the time. We use them to like uh type notes about our patients
Mm,
and because of that I can do a note in 3 minutes where it might take a colleague 8 minutes because I've figured out all the tricks and everything like that. Um and then within research, so I do a fair amount of research as well.
right.
And like that has really helped me a lot. But I find that like there's an engineering mindset, and that
Mm,
mindset is um if you compare it to the scientist mindset is there is a problem, or I'm sorry, the engineering idea is there's a problem. How do I fix it? And I think the with what I have, well, the scientist is like, I need to identify what is going on in particular scenarios, and then later someone else can figure out what to do about it. Is
right.
usually what it is. And so for me, it's like someone comes into the clinic and they say, this hurts and this hurts, and this is what's going on. To me, it's kind of like, well, what do we have? What tools do we have available that we can use to kind of engineer their recovery?
Hmm.
And so I find it actually is a reasonable mindset. And there's a lot of engineers who are in medicine, and I find it actually works pretty well for diagnosis and treatment. Um, and the stereotype of like the nerdy, unable to talk to others engineer. Most of those people in medicine kind of grow out of that, which is nice. But man, a lot of my engineering colleagues really fit that stereotype before.
Right. I mean, that's good that it gives you that analytical mindset that maybe, some of your colleagues without an engineering background might not necessarily have it. And 3 minutes notes, that is a big flex. I envy you, and I just look forward to the day that, I feel
That's an
like
exaggeration.
at a med student pace, I'm like 30 minutes, but slowly, hopefully, by residency, I can be a little bit faster. Um, but that's really good to know. Thanks for sharing. So, um, about one of the things that's pretty unique about you is, like you said, medicine is movement, and that seems like something that you are passionate about. So, can you talk a bit about your conservative approach to treatment and how specifically you use exercise as medicine in your practice?
Yeah, I think that if you look at kind of the natural recovery of most musculoskeletal injuries, they tend to be the body healing itself. That just generally is how it works. There's surgery. Surgery definitely plays a role in some things. But the majority of things are non-surgical. And in those cases, it's not us sticking a needle in something that fixes it. It's not doing some type of intervention. The vast majority of what we do ends up being physical therapy or time. Like a lot of times, that's just what we do. And so I think that in sports medicine, there's been a shift as time has gone on to more and more ultrasound, to more and more injections, those kind of things. I don't know if that's good or bad, but I think still, if you were to just take a step back and look at it all, it tends to be no, it's actually more letting the body do its thing, but just kind of helping the body do its thing. And I know it's cliche, but it really is the number one most important thing for humans in this day and age is exercise. It just is. That's what controls cancer, or it decreases the risk of cancer, decreases the risk of pretty much every single disease we know about. But it's still a challenge to implement in a lot of cases. And I find in my patients here in Utah, it's either the people who are really fit or the people who are really unfit, and there's not much of a middle ground. And the really unfit patients, actually, they in a lot of ways are almost easier to fix because if you just get them moving, they do a lot better. Their mental health gets better. Whatever problem they have, it does a lot better. So a lot of times people do amazing there. It's the really fit ones who have gone over the edge and done a little too much or have a problem that just won't go away. Those are the ones that are a lot more challenging. But even with those, most of the time, it still ends up kind of how you load your tendons, how you load your bones, everything like that. So it still ends up being kind of revolving around exercise.
Mm-hmm. Um, you actually touched on one of, like the osteopathic principles as you were talking about it, because, as a DO, that's something we talk about: mind, body, spirit, and relying, and actually the fact that our body has all the toolkits to be able to heal itself. And I think, sometimes with medicine, we become impatient and we like for the result to come as quickly as possible rather than, like you said, just give it some time and be patient. And it's not necessarily like sticking a needle that can fix the problem. And also, that's really interesting with your patient population, because I would think it would be harder to motivate those who not necessarily come from an athletic background, but sounds like it's easier for you. Um, to help those that potentially come from
Uh,
sedentary backgrounds?
it is definitely harder to motivate them.
Okay.
What I mean is more of if they do it, they generally do really well.
I
And so
see.
if you can get them into even not necessarily physical therapy per se, but a lot of times just an exercise routine,
Mm,
talk about the importance of habits, talk about the importance of starting slow and not overdoing it, those kind of things. Um, I've yet to have a patient who started something, who was overweight, who had just didn't had a poor exercise tolerance. I've yet to have a patient who wasn't glad they did it.
right.
The problem is many of them don't do it.
Mm. What have you found to be helpful in, pushing them to that step of like, let's do this? And it's hard to instill habits, right? I think a lot of people are looking for that quick fix, or that what is the shortest thing, the fastest thing that I can do. But I guess it's a lifestyle, right? Being active, being instilling those type of habits. So what have you found to be helpful?
Yeah, and I think it's different for every person. So I think that's probably the
Mm.
most important thing is there's not a one size fits all. I do think that talking to the person, finding out what makes them tick, finding out their habits, finding out their barriers, those kind of things, that really makes a big difference. And I don't claim to be the expert on this by any means. But I think finding a reason for them to care is
Right.
number one. Second is having some kind of habit. Third is finding a very attainable goal, and not just one that's they can probably attain, one that they can attain. And that can even be like, look, if you're watching TV from 8 p.m. to 10 p.m. at the commercial, I want you to just stand up. Like anybody can do that, that
Yeah.
type of thing. Or, if you have a dog, walk the dog every day, no matter what, just walk it, rain or shine, just walk the dog. Those kind of things. And then pretty soon they find, actually, I kind of like that. It's kind of nice. Um, there are days where it's hard, but if you make it to the point where you have to do it every day, they do it. It's when they're like, it's just easier not to. And so I think those are the big things. But it's different for everybody. So for some
Mm.
people, that's a really bad advice, and other people, it's just good advice. So I don't know. I feel like it's very case by case.
Right. I appreciate you highlighting that because, like you said, it's not one size fits all and everyone is different. And what you talked about goal, that is so, so important because it's so easy if you don't have an end goal in mind, whether that is like, oh, I want to be able to go on a run with my family or even go on a hike without feeling super short of breath. Those can be things that definitely can encourage someone to hopefully adapt a more active lifestyle. Um, so as a team physician for, the multiple university sports teams, can you share some insights into the challenges and rewards of providing medical care to collegiate athletes?
Yeah, and I think that's one of my favorite parts of my job is that in that it's a lot of primary care, which I really like. Other people not so much, and I find people who are in PM&R oftentimes don't enjoy that. I really like that part of things. I like real world medicine, um, and I think that is also a challenge because I wasn't trained like a family medicine doc was, but at least in my fellowship, I got a fair amount of training in it, which really helped. And I kind of understand my limitations and know when to talk to colleagues or refer, that type of thing. And I think the stuff we were talking about with the time of like, well, we should just let this heal. That's not always an option, or it's not always, or there are other ways around it. So, for example, someone has, I'm just thinking of as an example, it has a tendonitis that's happening the day before national championships.
Oh
I'm going to
man.
treat that very differently than some who gets the same thing the day after national championships. Um, and so, it's the same thing where we treat those all very differently, and those are the biggest challenges. And if you contrast it to like professional sports, which I am not a fan of, I mean, I
Yeah.
like watching sports, but like I'm not being a team doc, it's all politics. It's you have to take into account not just the well-being of the athlete, but you also have to take into account a lot of other factors, the main one being money. And collegiate athletics, a lot of that is seeping in, but at least for where I am, there's none of that. The coaches are great, the athletes are great, the medical system is great. And so we have the athlete's well-being at heart. But at the same time, if you're like, well, you could run tomorrow and you might end up with more pain later. In my opinion, that's for the benefit of the athlete. Yes, they'll have more pain, but they also got to run the race they wanted to run, which they've been training for their whole life.
Right.
Um, those types of things, you have to take all those into account. And so most of the time with as a team physician, it should be a discussion with the athlete. You should put their health first. But it's not as simple as just being like, well, you're going to hurt tomorrow, so we better pull you out. You have to make those decisions, and they're virtually always a gray area, not a black and white.
Hmm. Gotcha. I think that was a very good advice for people who do aspire to be team physicians and um, dealing with those gray areas more so than this is the protocol that we all follow. That sometimes I feel like, for instance, in a hospital setting, that might be more prominent if there are like rules and like specific protocols. You also touched on primary care, and I'd be very interested to hear your insights on the difference between, going into sports medicine from a PM&R background versus, let's say, family medicine.
Yeah, and so to get into sports medicine, there's the surgical route, which is ortho, And there's the
Mhm.
non-surgical route, which is emergency medicine, pediatrics, PM&R, internal medicine, which is fallen by the wayside, and family medicine. And within those different cohorts, they're very different. They all have their own advantages and disadvantages. And our fellowship at Utah, we have a pediatric, an emergency medicine, a PM&R, and a family medicine fellow. So I've seen all of those, and I see the pluses, I see the minuses. So I feel like I can actually comment on that pretty well. I think the biggest downside to PM&R is the primary care side of things.
Mhm.
I think the biggest upside is the musculoskeletal and neurologic knowledge. If I were to just put gross oversimplifications as to how it works, generally peds works with kids. They're really good with kids. Emergency medicine, good with event coverage, acute injuries. Family medicine, good with holistic care of the athlete, including primary care issues. PM&R, really good at diagnosis and neuromusculoskeletal care.
Mhm.
I find that a lot of people within PM&R get into the PM&R world and they say, "Oh, I want to go into sports medicine." What they think is, I want to deal with sports injuries in a clinic using ultrasound and doing injections. That's usually what they think of it as. But outside of that, that's not really it. So sports medicine as a whole is also taking into account um, primary care issues with athletes, event coverage, which can include acute injuries, and then also just kind of the political landscape that's involved with all of it. So I find that PM&R has its own narrow window, but the other ones also have their own narrow windows. And so I usually tell people, if you're in med school and you're thinking about where you want to go, PM&R is not always the best route for you. Sometimes, like, some people love the family medicine side of just seeing everything and then still being able to do sports medicine. And other people are like, I really like spinal cord injury and stroke and brain injury as well. That's a great avenue for PM&R. But I find that when people are like, I'm so focused on sports medicine, that's what I want to do no matter what, and PM&R is the best way for me to get there, they're going to really not like their residency too much.
Mhm.
And so in general, it's kind of what is the other aspects of sports medicine that you like, that's probably what's going to lead you
Right. That is such a good advice because I feel like especially for us medical students, it's sometimes you do very much so think about the big dreams like, oh, I want to be a I don't know, one of my dreams at one point was like, oh, I want to be like a WNBA team physician. That would be so cool. However, like the route to getting there, right, it could be very different. And if, like you said, sports medicine is the end goal and you don't necessarily care for TBI, spinal cord injuries, then yeah, maybe you
there.
might want to
Yes.
choose a different residency compared to PM&R.
One of the family medicine attendings when I was in med school said this to me. I think it was the best advice I got, which was, find the worst part of any specialty, and if you can stand it, that's your specialty. And I
Mm,
think that that's it. And so I feel like in PM&R, a lot of people are like, it's chronic low back pain. Can't stand it. I don't want to deal with that. I don't want to be a back pain doctor. That's how people view PM&R a lot.
right.
Family medicine, it's dealing with hyperlipidemia and diabetes and tons of medication management. Emergency medicine, it's dealing with those patients who come in the ER just looking for pills, those kind of things. They all have their negatives. And that's the day to day. So if you can stand those day to day things, you'll eventually get to the type of career you want. But at the beginning, it's going to be at least 5 years of doing stuff you don't want to do. So you may as
Mhm.
well not hate it. If
Yeah,
you hate it, it's a bad sign.
right. That is such a good advice. I definitely will add this to my collection of quotes that I have from different physicians. No, I really appreciate that. Um, so talking about sports medicine and to my understanding, it does sound like there's a lot of overlap because the way a PM&R physician thinks about functionality, movement, seems like there might be some overlaps in sports medicine as well. But specifically for you, how do you integrate these two different fields in your clinical practice?
Well, my clinic's a little strange because I'm half research-ish, half clinic.
Hmm.
I do EMGs for a day a week, and that's by choice. I really like EMGs. Um, it's not something that I have to do, but I just enjoy it. Um, the other 2/3 of my practice is technically all ultrasound, and that was only it's a long story, but basically it developed into that, not by what I was planning on doing. Within that, I see a fair amount of clinic patients, but they're all based on referrals. So one of the physical therapists would be like, can you see Cushman? So within my typical practice, I end up seeing all the challenging patients. So I see the ones who've seen 10 doctors and haven't gotten better, and then they want one more opinion, that type of thing. Because of that, a lot of times I find that there's kind of two things that I see repeated over and over if I'm able to figure something out that someone else can't. The first one, hands down, is the patient just keeps saying and nobody's listening. The
No.
patient's like, I've been saying it's my shoulder forever, and everybody keeps saying it's my neck. And if even though they can't say what it is, they're feeling it. They know what it is. Or it'll be something in their history where they're like, yeah, I had this severe pain for a couple of weeks before it started. Then I got weak. They'll tell you these things where they've been saying it, but people just haven't been really listening. And then the second thing I think is probably a knowledge of anatomy above all else.
Hmm.
I think that having a really good knowledge of anatomy means more than just about everything in the musculoskeletal world. And it can be esoteric anatomy, but those are the challenging ones. So I think that for PM&R really does help you with that side of thing, the latter. And I think just a good doctor is going to be the former. It's not easy in common practice nowadays. Just don't have much time to see patients and get a good history. But I'm sure you've all learned this in med school. But when they say like history is 95% of the
Yeah. Mm.
diagnosis, man, it is true. Might even be higher.
Right. Yeah. Um, yes, listen to your patients. Very important because at the end of the day, the patients are the most expert in their own body and their own pain. Um, and I think it is challenging at times, right, with how short sometimes the visits can be and how much time you have as a physician. You can't give all your attention, um, or like, all the time in the world to your patients, but then that's the art of medicine, right? What works for you and how you can get the most of the information and help your patients in that short amount of time that you have. Um, so that's really good to know. So we're going to shift a bit of a gear and kind of go or talk about traits and advice that you have for aspiring sports medicine PM&R physicians. So what would you say are some characteristic traits that would make a qualified sports med PM&R physician?
I think it depends on what level you're at. So if you're in med school, my strong advice is um, be involved with PM&R over being involved with sports medicine if you want to do that route. And the reason for that is because, like I was talking about earlier, if you don't like PM&R, you're going to have a miserable 4 years. Um, and if you find like, man, I don't like this, and you're doing PM&R, even though your goal is sports medicine, um, you will thank yourself later because pretty soon you'll find, actually, I'm going to do emergency medicine. I can still do sports medicine, but I'm going to do emergency medicine or whatever it may be. If you're in PM&R residency and you have an interest, I would still say your number one priority should be learning as much as you can in residency about PM&R.
Hmm.
That will always serve you well. If there is a great research project that is related to stroke and you're still thinking, I want to do sports medicine, do the research project in stroke. I don't think anybody is going to think, why did you do this one? They actually really respect it. If you're like, I just really like PM&R, but I'm still doing sports medicine. And then the final thing I would say is like, find out as much as you can about what it actually entails.
Hmm.
So a lot of PM&R residents don't really want to do coverage. And if that's the case, I'm like, that's part of the deal. That's part of the package. Consider doing general MSK or consider doing something like pain. If you're like, I really just want to be in a clinic, see patients, and then do injections. That's not sports medicine. And I think that people who have that mindset and go into sports medicine end up being disappointed with what they ended up doing. So
Hmm.
find out as much as you can about it. And keep in mind that every sports medicine doc is not the same. So if you're around one sports medicine doc, like this is the best thing in the world, it may not be. That's just what they've developed, especially if they've been in practice for 20 years and been able to build that. Or if you see, you're like, this is the worst thing in the world, that may just be the one. So try and get kind of more of a breadth of experience with it too.
Hmm. That's a great advice, especially with the fact that PM&R is such a broad field. And even myself, like I feel like every day or every conference that I've been, I learn something new. And that's why I feel like doing away rotations becomes even oh so important. So you can learn more about what it can be. And it sounds like maybe even doing a sports medicine rotation with a PM&R physician, that could be pretty helpful too. Um, so for our last question, what would you say or what advice do you have for students and or residents who are interested in pursuing PM&R with a special interest in sports medicine? And I feel like you've kind of touched on it a little bit.
Yeah. Yeah, I think what kind of the stuff I was talking about that last one, but I think also like I said, if you're a student and you're like, I know I want to do PM&R, but I'm not sure if I want to do sports medicine, that's the right thing. If
Right,
you're like, I know I want to do sports medicine, but I'm not sure I want to do PM&R, that's when you got to look around. You got to
right.
look at all the different ones and be like, peds, emergency medicine, internal medicine, family medicine, PM&R, or ortho, and see which one you like better, because that will make you so much happier in the long run
Mhm.
rather than being like, well, that one just seems like the way so and so did it, or that's the way the one doc I saw did it. It's not the way to go. There are actually far more family medicine fellowships in sports medicine than there are PM&R.
Mhm.
Um, and so meaning like just make sure you do what's right for you. I obviously think PM&R is great. I kind of recommend it to everybody, but at the same time, it's so much better for the student to be in the residency they enjoy rather than being the one that I like. It
Right.
doesn't help anybody if that's the case. So find the one that best interests you.
Right. Well, thank you so much for that. And there you have it, folks. This was an awesome episode. I hope you guys learned as much as I did. And really take the time to reflect about what it is that you want and keep in consideration that necessarily, what you are going to end up doing, a lot of it will be from your residency, sounds like it, rather than just a mere focus on your fellowship. And with that, thank you so much, everyone, for listening to this episode. And if you have a few seconds, please leave us a review on Spotify or Apple Podcast page and let us know what you'd like to learn about in the future. Until next time.